Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Welcome to the Gastro Girl podcast, your trusted source for expert insights on digestive health. I'm your host, Jacqueline Gaulin, and today we're exploring a crucial topic for those managing IBS-C, understanding different treatment options and how they work. If you'd ever wondered what terms like Secretagogues and Retainagogues mean and how they impact IBS-C symptoms, this episode is for you. And joining us today is the amazing Dr. Darren Brenner, a renowned expert in neurogastroenterology and motility disorders. Dr. Brenner is a professor of medicine at Northwestern University Feinberg School of Medicine, where he specializes in diagnosing and treating complex GI conditions, including IBS-C. We're so thrilled to have him here today to break down the science behind these treatments and help patients better understand their options. And this episode is brought to you by here we are talking about some exciting topics. It may not be a sexy topic, but it's an important topic. We're talking about secretagogues and retainagogues and what the mechanism of action for each of those are and what patients need to know. And this is for treatments of IBS-C in particular. And before we dive into this, just if our listeners are joining us for the first time, if you could kindly give a brief refresher on what IBS-C is and what makes it different from IBS and other types of IBS.
Sure, happy to do it. But it's funny, you said secretagogues and retainagogues, and all I heard was, oh my gogs.
Oh my God, that's a good one.
We'll put some Janet Friends references into this for people from my generation. But, irritable bowel syndrome is a very common diagnosis and disorder. It affects probably clinically 10 to 12% of the world's population. Some people define it by strict criteria, which include abdominal pain that's better or worse with a bowel movement associated with changes in stool form, which can be harder, softer, a mix of the two, or stool frequency, less frequent, more frequent. A lot of patients, though, don't present with the classic pain component, but bloating, distension. After I eat, I feel the blahs, I'm full, I'm exhausted, fatigued, the technical term prostrated. So there's a lot that goes into this clinical diagnosis. So I always tell people, if you're having abdominal symptoms, pain, discomfort, bloating, distension, they feel different after a bowel movement, maybe better or worse. You're noticing more diarrhea or constipation. That could be irritable bowel syndrome, and probably a good idea to talk to your primary care physician or maybe even a gastroenterologist like me. Now, what's the difference between IBS-C versus the other ones? It's the frequency of the types of bowel movements you have. So here's where texture becomes important. And really, people with IBS-C are going to be individuals that have hard stools most of the time. We use, again, in research-based criteria, having hard stools more than 25% of the time and loose stools less than 25%. But most people just come in and say, most of the time my stools are hard. Now, what do I mean by hard? Well, we can get really fancy. For our audience, if you go online, look up the Bristol Stool Scale. This has been a validated poop scale that's been used for decades to qualify the different types of stools that are out there. And we really define constipation on this scale as type 1 or type 2. These are hard, lumpy stools. I know this is gross. I'm about to take it a step further. I apologize for this. But if you're passing stools most of the time that look like Milk Duds or Baby Ruth bars, you're probably on the IBS with constipation side of the spectrum. IBS with diarrhea is the opposite. These are people that are passing loose, mushy, watery stools. These are things that look like a clump of mud or a mud pile, people will say in clinic, or pudding or chocolate milk. So these are the things that fall on the D side. And then the mixed subtype are people that really swing between the two. They have constipation sometimes, they have diarrhea other times, but I like to add a little bit of a caveat to that because people come to clinic all the time saying I have the mixed subtype, but I like to differentiate, especially for audiences like this, so they understand what we're talking about. A lot of people come in and say, I have constipation and diarrhea, but they're taking laxatives. And I'll say to that individual, well, what happens if I were to take away the laxative? And they freak out and say, oh, I'd never go to the bathroom. They'd be hard as rocks. Well, that's constipation. That's irritable bowel syndrome with constipation. It's the laxative causing the diarrhea. And we're talking about your natural state, where you are with nothing on board. Another case where we see a lot of these mixed patients is what we like to think of as constipation with overflow. So if your clinical course is you don't have a bowel movement for 2, 3, 4, 5, 6 days, then you feel that urge or the push, strain really hard. You pass a couple of pellets. Think about it like a dam. Couple of bowel movements, the dam breaks and then everything floods out. You have 2, 3, 8, 10, 12 bowel movements. You feel better and the process starts all over again. That's probably irritable bowel syndrome with constipation as well.
Wow. I mean, you've made, for a podcast, you've given amazing descriptions. I'm sure if people are just listening to this, they can visualize everything that you've just said. And I think you've really hit home with these messages.
Or they're hanging out because they're having their coffee.
Or they're just like, don't want to listen to the podcast ever again. Please don't do that. But seriously, we make light of this in an educational way because we don't want you to feel embarrassed. Dr. Brenner sees this day in and day out. Healthcare providers are very familiar with patients with this struggle. You're not alone, and don't ever be embarrassed. And he gave good ways to explain it. The Milk Duds, Baby Ruth. I think that's brilliant.
And it's a key part. Don't be embarrassed by this. Again, this is a very common disorder. I make light of it because I want people to think about it in a more relaxed way, but I'm very honest and open and will tell your listeners and your audience, I have irritable bowel syndrome. So I will never minimize the types of symptoms or responses or quality of life impact that people are experiencing from this disorder.
No, and thank you. And for those who want to dive deeper into IBS-C, Dr. Brenner has also done several other episodes with us. You can find those on our playlist. He dives even more into lifestyle and diet, as well as the mind-body connection. But today we're specifically going to talk about the, oh my gogs, I love that, Secretagogues and Retainagogues, and what they are. So let's just dive into this. Can you start by explaining what they are as a treatment option and how they work?
Sure. We're always looking at ways to differentiate the type of therapeutics so that when people come in, we can explain some of the differences between them, the pros and cons. We don't like the term laxative. Laxative lumps everything into a probably century-old phrase of I guzzle something, I take a little pill and I explode with a bowel movement. That's not what we're looking for. So there are currently 2 FDA-approved classes of therapeutics for treating irritable bowel syndrome with constipation. The earliest class was the class called Secretagogues and contains 3 different therapeutics. One is called lubiprostone. It activates chloride channels in the GI tract. Another is called linaclotide and activates what we call guanylate cyclase C receptors in the GI tract. And then a cousin of it, plecanatide, which is also a GCC receptor or guanylate cyclase C receptor agonist. Now, why are these called Secretagogues? Because all of them, by little differences in mechanisms of action, cause the secretion of fluid into the GI tract. So it makes sense. If you secrete fluid from your body into the GI tract, why not call it a secretagogue? Now, why is that important? It's important because we want individuals to understand the mechanism of action. We want you to know why things work. And we want to drill down to a very non-scientific, basic way of thinking about it. So let's look at it this way. Let's say there was a hard stool in my GI tract and I added water to it, which is what's happening. We're secreting water into the lumen. Well, what happens when you take something hard and you add water to it? You make it softer, okay, which is going to make it easier to pass. But at the same time, by adding water to the intestinal lumen, you actually stretch the wall of the intestine, which increases movement and motility and pushes the stool faster through the GI tract. And there have been lots of studies that have shown that the faster things go through the GI tract, the softer they come out the other end. So we understand why a medication like a secretagogue could play a role in improving bowel symptoms like frequency, straining, the sensation of incomplete evacuation, the texture of the stool, taking harder and making it softer. Where there's a little bit less of an understanding is how it improves the abdominal symptoms like pain, discomfort, bloating, and distension. For lubiprostone, which is the oldest of the secretagogues, we really don't know. And for the 2 newer medications, the linaclotide and the plecanatide, there have been animal models and preclinical models that have shown that some of the molecules that are produced in the cells by these drugs actually have a way of going to the pain nerves or pain fibers that are in the GI tract and telling them to slow down or stop firing as aggressively bad signals of pain towards the brain. So we understand that a little bit better. The newest class, the first approved in that class in 2022, is a medication called tenapanor. And tenapanor we called a Retainagogue because of the way that it works. So this is a therapeutic that actually binds to not receptors, but channels, sodium hydrogen exchangers. And what it does is it blocks the absorption of sodium from the GI tract. Again, you don't have to remember this. All you need to know is that by blocking sodium's reabsorption, you retain water in the lumen. So you're not secreting any water at this point. You're retaining water in the intestinal lumen, and it has the exact same properties for improving stool symptoms, softening stool, increasing peristalsis. But where I think this one is different is in the way that it improves pain. Because it does not necessarily go to these nerves, it has a couple of different actions. Number one, it basically blocks what we call TRPV1 receptors, or we call them red hot chili pepper receptors, not to be confused with the band from California. Okay.
Love that band. Love that band.
Me too. Big fan. And I'm hoping to see them at the Olympics because at least they did the the last Olympics out of Paris. But by blocking these receptors, and these are hyperalgesic receptors, so that means that they cause pain. By blocking them, you reduce the pain component. But we also know a lot of people with irritable bowel syndrome, especially those who have post-infectious irritable bowel syndrome, have abnormalities in the way that the gut environment, and especially the bacteria, interact with our immune system and the nerves in our GI tract. And these abnormal interactions can cause changes that lead to increased pain. A lot of our naturopath friends, they call this leaky gut syndrome. That's not exactly what it is. We like to think of it more like a microbiota immune interaction that is aberrant. And we know in a lot of these inflammatory cases, we see basically a loss of what we call a tight junction. So there's separation between the cells in the intestine, and it allows the organisms in the GI tract and toxins and other things to interact with the immune and the nervous system outside of the GI tract. What this medication has been shown to do in preclinical trials is actually close those junctions and thus block those communications. So it's a completely different mechanism from the pain, discomfort, bloating perspective.
Now, this is so interesting. As a patient myself, I always like to understand the mechanisms and how things work. And then I think it helps to be more open to trying these new treatments and not being fearful of them when you understand how they work.
Yeah, I think it's important to ask your practitioner what they're giving you and what the other options are and why they consider using it. I mean, I'll tell you in my clinical practice, very infrequently do people say to me, well, what's the mechanism of action? How does this work different than something else? I appreciate the fact that individuals are trusting in what we know and what we can do. But a lot of times it's just, take it on faith. This is potentially going to work for you, but ask those questions. Why do you think this will work for me? What's the mechanism? How does this fit my symptom profile? And quite honestly, in some cases, we won't be able to answer that. We'll just say, look, we know it works in irritable bowel syndrome. We haven't answered all the questions and we'd like to try it. But in other cases, we have a little bit more data and we can provide that information for you.
Yeah. And this brings me to my next question. So how do these medications differ from other treatment options that are available that may be first line, what you prescribe or you tell the patient that they should try first? And are there specific patient populations that would benefit more from one versus the other?
Yeah, I think, especially when we're talking about irritable bowel syndrome versus chronic constipation, which we've talked about in the past, the differentiator has always been that people with irritable bowel syndrome should have pain. But people with constipation can have pain as well. So for a long time, I've been making the argument, it's not the chronic constipation versus irritable bowel syndrome with constipation label that you can get from a practitioner. It's, do you have pain, yes or no? And if you have pain, then these medications we just talked about, the Secretagogues, the Retainagogues, from my perspective, should be your first-line agents because there have been numerous clinical trials looking at thousands and thousands of individuals that show that they can help the pain piece. This is unlike lots of the other products that are out there, the PEG 3350s, the Bizacodals, the Senas, the Colaces, those types of things. While many of these work very, very well for bowel symptoms, again, frequency, texture, straining, incomplete evacuation, none has been validated in clinical trials to ever help the abdominal symptoms. And in many cases in clinical trials, some of these products have been shown to worsen those symptoms. So they're going to make the individual more uncomfortable. So when I see a person who comes in with constipation, I go to that pain, discomfort, bloating, distension piece, and I say, okay, if there's an abdominal symptom piece, my algorithm is different than if it's just a constipation piece. Other things people use. Probiotics. We do not have a lot of data on probiotics. We do not recommend probiotics at this time. Yes, there are some trials out there that show they work, but which ones, in what concentration, for how long has yet to be determined. A lot of people first line use antispasmodics, and antispasmodics are great. Pause. For abdominal cramping. They help cramping. They have never been shown to improve global symptoms either. So these are things that I think should be used as adjuncts in this process that many people use first line, which unfortunately is not going to get the global process or the totality that is IBS symptoms and the symptom profile for this disorder.
So the next question is, when you're looking at a patient and their history, what factors do you consider to know which one to provide to that patient? Like which mechanism of action is best for that patient?
Yeah, so having a few different therapeutics now is a blessing and a curse. It's easier to talk about the curse because the reality of the situation is there are no head-to-head trials in individuals with irritable bowel syndrome of any subtype, including constipation, with these therapeutics that tell us whether or not one is going to work versus another. They have all been shown to be more effective than placebo. They have all been shown to help both abdominal and bowel symptoms. So I usually go back to what I call my 4 C's, okay? And the first 2 C's, from my perspective, are not the most important, but the reality of the situation is that they are. And that is cost and coverage. Because if it's too expensive, go back to your practitioner and say, I can't afford this. What else you got? Okay? If it's not covered, it's probably going to cost a lot. And then there's comfort. Are you comfortable taking this medication? Is the patient or is the practitioner prescribing it comfortable with it? What are its properties in terms of effects? How long does it take? What are the side effect profiles? And then there's compliance. If you have to take something once a day versus 3 or 4 times a day, that can be different. Every individual that comes in with this process has a different story, which is the beauty of treating irritable bowel syndrome, because there's no one size fits all for everybody. So I like to know about that. But at the end of the day, I always tell people, don't get frustrated with the process. And if one doesn't work or the second one doesn't work, don't think necessarily that the practitioner is just throwing pills at you because they can. There really is a trial to error process in this game. Some people will work within the same category. Some people will go from one secretagogue to another secretagogue. I've seen that be completely effective. I've seen other people start with a Retainagogue and go to a secretagogue or vice versa. That can be effective as well. So work with your practitioner. Keep an eye on what is improving, what is not improving at all, what is worsening, because based on that, even if there's a partial response to therapy, there may be little things that we can add on as opposed to calling the therapeutic a treatment failure. One other thing, when I talk about treatment failures, taking a therapeutic for 3, 4, or 5 days and not getting a response is not a treatment failure, okay? As a patient, I will say this. This is a patient failure. We have to give these drugs a few weeks, if not a month, to see if they're going to be effective.
You just stole my thunder, Dr. Brenner. I was going to ask you that question. But seriously, a lot of patients do that, myself included. Okay, it's working or it's not working, or it works and I stop taking it and then I'm like, oh, I have it. So let's drive this point home. Give it time, be patient, right?
100%. Yes. If you don't get the response in a few days, don't give up. I always tell my patients, or I always give my patients rescue therapies. You want to ask your practitioner, is there something else I can use while this gets into my system or starts to work? And I see if it's effective, that if I go 3, 4, 5 days, because it doesn't kick until week 2, week 3, that I can use. Part of the reason patients give up on these therapeutics is because they feel miserable. They take them for 3, 4, 5 days. They're like, I feel horrible. I'm done. I'm going to go slam some over-the-counter laxatives as much as I need to poop. I'm through with this. I'll contact my practitioner. So again, ask your practitioners what you can use every few days while your body and your system is working through the process to see if this is going to be effective.
Yeah, because like when you explain the mechanism of action, there's something that's happening on the cellular level to draw in that water or to hold the water in, so it doesn't just happen, boom, like we're good, let's go.
Exactly. When we're talking about modifying nerves in the gut, neuromodulation takes time, no matter what the therapeutic is. So we've all done multiple studies looking at many of the therapeutics we talked about today, and we know that the bowel symptoms always get better before the abdominal symptoms. So give it more time to see if you get that abdominal response.
Thank you for that. And our patients always ask, in my, one of them too, safety. The safety data is pretty good on these drugs, correct?
Yeah, the safety data is not great on these drugs because the reality of the situation is the vast majority of these have minimal, if no, systemic penetration. They do not get out of your GI tract. They work on receptors in your GI tract. They break down into amino acids, if you remember baseline high school biology, and they're pooped out the other end. So really, the major side effect that we see for the vast majority of these is diarrhea. But for people, diarrhea in most cases is mild to moderate. Sometimes it's the first week. I tell people the first week your body may just purge its system and then normalize. So we want people to be aware of that. Other people come in and say, hey, I love diarrhea. Well, there are extremes of diarrhea. You may not love what you get. It's another reason why I say give it a little bit more time. But overall, these drugs are very safe. Most of them have no drug-drug interactions. So if you have other medical illnesses and you're worried about that, you don't have to. They really don't penetrate your system or your other organs. So they are very, very good therapeutics to use for IBS-C.
So as a neurogastroenterologist, you're really well versed with the gut-brain axis. And, a lot of times patients have anxiety around starting a new treatment and what to expect. They're maybe a little fearful. Do you give your patients other tools that can maybe help with some of that anxiety? Do they work with GI psychologists? And how do you, explain to your patients about maybe trying those routes?
Yeah, so I consider IBS a multifactorial process, and that's why I said no people are the same. I've had people come in with flares of their IBS because, unfortunately, their cat died the night before, or they ate out and got sick, and food poisoning flared their IBS symptoms. So there's lots of mediating and modifying factors. A multidisciplinary approach to this disorder, from my perspective, is key. And that's why at Northwestern, I am privileged to have a couple of expert dietitians, 6 brain gut behavioral therapists that I work with on a regular basis. And the data in the literature shows that integrative multidisciplinary approach works better and is actually more cost effective. So if you have anxiety, concern, if you feel like stress worsens your symptoms, looking for somebody that's well versed in brain gut behavioral therapies like cognitive behavioral therapy, gut directed hypnosis, mindful meditation can be a great adjunct. I hate to use the term adjunct, but in clinical trials, it's always added on to medicines. In our clinical experience, I'll tell you that you can do behavioral therapy on your own and get better without having to take pills. Diet plays a major role in people's symptoms. People always say to me, do people come in looking for dietary advice? I say, yeah, but most of the time they figured a lot of it out before they even walk in my door because it's a major trigger. So having dietitians that can help them define foods or food categories so that they're not restricting or avoiding all the foods that are out there is really important. I always say you can live to eat or you can eat to live. I live to eat. I think most of the patients I see and people I talk to on a regular basis do the same. So I want to minimize the amount that you're restricting as much as possible. And we can help do that.
Well, especially living in Chicago, you have great restaurants there.
Yeah. Love the food here. And anybody who wants to disagree, you're wrong. Chicago food is 1,000 times better than New York's.
I love it. Yeah, I've been there several times for conferences. There's some great options there. Really, really great. I love asking this question because you're always on the forefront of research and what's coming down the pipeline. So what's coming down the pipeline? Are there any emerging treatments or research developments in IBS-C that patients should be aware of?
There aren't a lot of drug studies going on, quite honestly. We're looking at a new antispasmodic, a different formulation. There are some very good antispasmodics around the world, but the ones that are available right now in the United States, they just don't do it. Again, they don't get the global symptoms. So we're looking at those. You're always looking at more natural interventions. People are doing more probiotic studies. I am begging, pleading, kicking, and screaming for a highly validated, rigorous, scientific probiotic trial. Again, there are probably, I may be hyperbolizing a little bit now, but hundreds of probiotic studies looking at treating irritable bowel syndrome, but none of them are scientifically rigorous enough for us to extract good data to make true recommendations for individuals. And then there are more of the brain gut types of things. Virtual reality. Virtual reality is going to have its place coming soon. People have those headsets. They can download programs. I have colleagues that are looking at that. So a little bit more out of the pharma realm than we've seen in the past.
Yeah, the probiotic thing, I'm with you on that. I would be kicking and screaming for that too, because we have so many patients ask about that. And there's so much noise on social media, and it's probiotics, prebiotics are in everything, even like soda pop, right? Or
Right.
people are so confused.
I tell people, I'm like, when they ask, what about probiotics? I'll give you my honest answer. It's yes, there's the potential that probiotics can help. Do I believe that altering the gut microbiota, microbiome, metabolome, a conversation for another date, but those are three completely different things, will improve GI symptoms? Wholeheartedly. Not only GI, but I believe it plays a role in allergy, immunology, rheumatology, and many other disorders. We know that the adrenal axis is impacted by the gut microbiota. So this is probably the future of medicine, but we're not there yet. So if people come in and say, can I try a probiotic? I say yes, because most of the data says that these are safe. But here's what I tell people. Try one at a time. Take it for no more than a month. If you get a benefit, fine, continue to take it. If you don't waste your time, effort, energy, or money. Again, I think the vast majority of these are safe. But if you come to my clinical practice and you say, okay, Darren, you said I could take a probiotic, which one? All I'm going to say is any that comes from a reputable company where if you have a complication, there's an actual number on the box where you can call and get a human being. Other than that, I really can't make any more definitive recommendation.
No, that's great advice. And we've had other experts and your colleagues on saying the same exact thing. Right. And even if I ask them 7 ways from Sunday, what probiotic? Can't tell you that. Same answer. I try, patients. I try. The evidence isn't there.
Right? We want to give you that information as bad as you want it. We just don't have the science to give you honest answers.
No, and we appreciate the evidence-based approach as always. Before we wrap it up so you can get back to saving lives and helping people with their IBS-C, seriously, any final tips for patients that are considering or want to talk to their doctor about some of the new Retainagogues or Secretagogues that are out there for them?
Yeah, I mean, again, if you've tried all the old therapeutics, this Retainagogue came out just a few years ago. Again, its name is tenapanor. Talk to your practitioners about this. A new mechanism of action that I think is very beneficial, very plausible, different for pain, especially if you have pain symptoms, pain, discomfort, bloating, distension. I label all those under the pain spectrum because from my perspective, that's the way that IBS patients present. Any of those are legit for me. And realize that there are always new things coming out, so ask us about them. If you see something online, if you see something on TV, feel free to ask us. That's what we're here for. And we'll be honest with you. If we don't think it's going to do anything, we'll tell you that. But I also want to stress the fact that, again, this is a lot of a trial and error process. So I don't want you to think that your practitioners are missing something, that there's probably cancer, that this is going to be a dangerous thing. It's just a disorder where, again, everybody is different. So everybody's response to what is out there is different as well. We're just thankful that we have so many options now in 2025 to be able to help.
Well, this has been, as always, just so much fun, but more importantly, so much education. And you really made it palatable for our listeners. And hopefully they're less embarrassed to talk to their healthcare providers about issues like IBS-C. Dr. Brenner, thank you so much for sharing your expertise today. Your insights help make these complex treatment options easier to understand. And I know our listeners truly appreciate it. If you are someone you know is struggling with IBS-C, remember there are treatment options available, and working with a healthcare provider to find the right fit is key. You can learn more about IBS-C treatment advances by visiting our website at askgastrogirl.com. You can also try out our new app, which is evidence-based AI-powered guidance that answers common questions and guides you to the right information so that you can feel more empowered and informed when you talk to your healthcare providers about your health circumstances. And a big thank you to our sponsor, Ardelyx, for supporting this important conversation. If you find this episode helpful, don't forget to subscribe to the Gastro Girl podcast for more expert insights on digestive health. And Dr. Brenner, we hope to see you and have you on again soon. Always a pleasure.
As always.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.